It gives me great pleasure to introduce Dr. Terry Davies for his grand rounds on pregnancy loss and thyroid disease. Dr. Davies earned his medical degree at the University of Newcastle in the UK. He went on to complete his training in internal medicine and endocrinology at the University of Newcastle as well, and then went on to complete additional training at the NIH and research before making his way here to Mount Sinai as faculty. Dr. Davies has distinguished himself in the field of endocrinology by making significant contributions to our understanding of endocrine pathophysiology. He has published over 400 papers on the topic of thyroid disease, spanning from immunology, genetics, to clinical research, mainly in the area of autoimmune thyroid disease. Dr. Davies' lab continues to be active researching autoimmune thyroid disease, and he is currently serving as the Florence and Theodore Baumritter Professor of Medicine here at Mount Sinai, as well as the Director of the Division of Endocrinology, Diabetes, and Bone Disease at Mount Sinai, Beth, Israel. Please join me in giving a warm welcome to Dr. Terry Davies.
So good morning. It's amazing that you're here on such a beautiful morning. So I appreciate it. July is hard to fill on grand rounds, Tuesdays, so it's a pleasure. I've given a lot of medical grand rounds over the years, but this is the first time I've actually approached pregnancy and thyroid disease, mainly because I'm frightened that Nathan Case is always in the front row, and whatever I say will be put right. So Nathan, I hope we don't make too many mistakes, but if I do, please shout it. So let's get rid of this. So it's quite a heavy series of points I want to make, so they'll be brief, but since it's July, I'm going to show you a bad case that's not entirely relevant to the rest of my talk, but I thought since it is July, we better go through something useful. Then we're going to touch on thyroid development and autoimmune thyroid disease, talk about some susceptibility factors that we know about now. That'll lead us into immune regulation and how pregnancy responds to that, and the physiologic changes in pregnancy that the thyroid undergoes. We'll touch briefly on how to test for thyroid disease to make sure you don't request too many unnecessary thyroid function tests. We'll talk then about consequences of thyroid disease in pregnancy. I am not going to touch on treatment of thyroid disease. You can read that up in Up to Date, or you can ask me at the end, but that's not what this is about. We'll talk about the consequences, and then we'll talk about pregnancy as a transplant. Right? It's 50% foreign. It's really just a transplant into the uterus. And then we'll touch on miscarriage and some causes of miscarriages in autoimmune thyroid disease. So that's the outline, and we'll see how far we can get. So it's very easy, right? Everybody knows that thyroid disease is really pretty easy stuff, right? Either the thyroid goes too high, or the thyroid goes too low, it grows nodules, some of them have cancer. That's it, all right? Okay. So let's do a case of one of these, right? You'll see that it's a July case from a very famous hospital in Philadelphia, which I won't name, right? So this is a 24-year-old female who arrives in the ER at 12:30 in the morning. She's 30 weeks pregnant. She's got vomiting, dehydration, tachycardia, fever, and a history of hyperthyroidism. So what's the diagnosis? Now, if it's going to be silence, it's going to be a really long round. What sort? Yeah, I think you'd call this storm, right? Fever, right? Vomiting, tachycardia, history of hyperthyroidism. This is thyroid storm. I usually say storm is in the physician rather than the patient, but it's accelerated hyperthyroidism in a 30-week pregnant patient. Right? So nothing happens until 2 in the morning when they actually put a fetal monitor on her. And it isn't until 3:20 in the morning that OBGYN is notified. What should have happened before then? Oh, I see, this is going to be a tough morning. Well, thyroid storm in a pregnant woman belongs in the ICU. Essentially, right? But they didn't do anything, they left her in the ER. Once OBGYN is notified, then a second-year resident comes down, and I'm not saying there's anything wrong with second-year residents. It's July, but it's a second-year resident, right? That was good, yes. Okay, so he notices right away that the fetal heart rate is down to 60, right? Big problem. He calls his attending. The attending says, we're going straight to surgery for cesarean, right? Do a cesarean. The baby has an APGAR of 2 with multiple issues. Mother has a cardiac arrest on the table. 20-minute resuscitation. They do get the heart rate back, but she never recovers, and she dies at lunchtime. So how do I get this case? This is a legal review, right? So the hospital asked me to review the case, and I'm supposed to defend the hospital. I think you can see that there's a whole series of errors here, so that the point I'm making is that pregnancy and thyroid disease is not to be dismissed lightly, right? And particularly hyperthyroidism, and particularly thyroid storm in pregnancy. Okay, so now I've depressed you. Let's talk about thyroid development, right? So this is a little schema just pointing out that the timing of human thyroid development. Up at the top, you'll see it's human and mouse in days. So it takes 84 days, right, before you get really well-differentiated thyroid cells. And going from budding and migration and moving down into the neck takes that time in a human, takes 16 days in a mouse. And the genes that are involved are shown on the left, right? One of the important ones is called PAX8, and I'll show you that on the next slide. But it's not till later in thyroid development that the important thyroid genes become active, right? The TSH receptor is first, and then comes thyroid peroxidase, thyroglobulin, and NIS, which is the sodium iodide symporter. Now you can do this in vitro. We actually can produce thyroid cells from embryonic stem cells. And this just shows you a couple of thyroid follicles made at Mount Sinai. On the left, you'll see that the sodium iodide symporter is in red, and PAX8, which is one of the key development genes for thyroid cells, is shown in green. And on the right, NKX21, which is the second important thyroid development gene, is shown in red, and thyroglobulin in green. So development in pregnancy, the baby has no thyroid until the end of the first trimester. Now, what about autoimmune thyroid disease? So that hasn't changed very much, except perhaps the view of it. And that is that families with autoimmune thyroid disease have both Graves and Hashimoto's in them. And these are really just variants of the same disease. It really depends on the immune response that is mounted. So if you mount a T-cell apoptotic-inducing immune response, you end up with damaged thyroid cells, and that's Hashimoto's thyroiditis. If instead the predominant immune response is an antibody that is able to act like TSH as an agonist and cause hyperthyroidism, then that is Graves' disease. And some of you may have seen patients that swing backwards and forwards between these two diseases. I have one patient who's done this 4 times, going up, going down, going up, going down. Just further proof that this is really the same disease with differing immune responses. So what sets off autoimmune thyroid disease? Well, we don't know. Well, we know a bit more than we did some years ago, but we basically don't know the cause of autoimmunity. This just summarizes some of the bits that we know. You'll see that we're talking about T cells, and I should have added B cells, going through a series of hits, right? These may be epigenetic, they may be developmental, but we do know that thyroid antibodies, right, indicate susceptibility to disease. Basically, anyone with thyroid antibodies, which is about 15% of women, less of men, everyone with thyroid antibodies has a thyroiditis, has lymphocytes, a lymphocytic infiltration, and that makes you more susceptible to thyroid dysfunction. We're going to talk a little bit about pregnancy and the postpartum, I hope. Infection, radiation, smoke, iodine, trauma have all been involved and shown as examples of precipitating via an environmental insult. And what matters, as I've stressed, is the immune response, whether it be antibodies primarily or T cells primarily. One point I should make is that the common thyroid antibodies we all measure as clinicians, anti-TPO and anti-thyroglobulin, these are not pathological antibodies, right? These are antibodies that are a response to thyroid damage, right? Whereas the antibody of Graves' disease, the stimulating antibody, is a pathogenic antibody. It causes the disease. So I mentioned it's all in the family. If you ask your patients, about 60% of patients give a history of Graves' or Hashimoto's, right? So that's less than some diseases. What percentage of type 2 diabetics give a history of type 2 diabetes? How's our staff knowledge of diabetes, never mind thyroid? What's the percentage of type 2 diabetes patients that give a family history? 40? Anything better than 40? Hmm?
Give a history or to have it?
Give a family, give a history, give a history.
Give history a lot less than actually have it.
So what do you think the percentage is?
That have it or give it?
That have it?
That have it probably like 80%.
Yeah, it's 80 or 90%. It's really very strong, right? So that the percentage in thyroid is less, but it's still pretty significant, right? These are family diseases, unless it happens to be the mutant, a first mutant. And there's a high concordance rate in both Graves' and Hashimoto's. So what does a concordance rate mean? It means that identical twins have the same disease. So then the question is, are identical twins identical? Oh, it's hard to get going here, isn't it? Come on, enjoy it. These are good questions. Are identical twins identical? I wouldn't be asking if they were, would I? So what's not identical?
They don't look alike.
They don't look alike? Identical twins? What's not identical about identical twins? Epigenetics is a very good answer, yes. What else? Well, that's the epigenetic influence, yeah. Remember that the V genes, the variable genes of the T cell receptor and the immunoglobulins undergo random, right, reorganization, right? So this is a random effect. So the two twins have different immune systems, right? They may have the same environmental influences, but they're undergoing random recombination of their V genes, and they do not have the same immune repertoire, right? Maybe similar, but it's certainly not identical, right? And so the fact that you get a high concordance between twins that have different immune systems suggests that there's a big contribution from non-immune related genes. And some of those non-immune related genes we know, but not too many. The thyroid autoantigen genes, thyroglobulin and TSH receptor, have been associated with autoimmune thyroid disease, but the associations are weak, right? And there's stronger associations to immune response genes, particularly HLA. HLA sort of dominates a lot of autoimmune diseases, but particularly autoimmune thyroid. When you do a whole genome screen, there's really nothing much else positive consistently except HLA, right? And there are some genes with unknown roles from these screens, but they are relatively inconsistent. The big change, I think, in recent years has been the recognition that the control of the immune system is very highly regulated by T regulatory cells, right? And we think these days that the ratio of T regulatory cells to a different subset called Th17, which are pro-inflammatory, that this ratio is important for the type of immune response that develops. And so once you lose T regulatory suppression, right, then the immune system, if you have inherited a susceptibility, that immune system will be allowed to let rip. When you go to look at Tregs in autoimmune thyroid disease, the data is not very good, but this is one of the first papers some years ago just showing you the difference or the defect. So this is shown as proliferation of immune cells that are then suppressed by T regulatory cells. And on the left are the controls that show a nice suppression there of 50%, right? Whereas the patients with autoimmune thyroid disease, if you take their Treg cells, they're not able to suppress as well as controls. And this has been interpreted as a T regulatory defect. Whether this is, well, the mechanism for this defect, I think, is still under review, but it appears to be important for acetylation of the FOXP3 gene protein, which is one of the markers of T regulatory cells. Let's now turn to the changes in pregnancy that the thyroid shows, right? You can't grow a baby and expand your body volume without important changes, right? There are clearly going to be, since baby has no thyroid, a significant need for more thyroid hormone during pregnancy. And so there is a high total T4 level in the blood, and that's because the thyroxine binding globulin that binds up T4 in the circulation increases. There's increased liver production, and there's an increased half-life due to glycosylation. Right? There's loss of iodide from the kidney, or an increased loss of iodide, because of the increased cardiac output and the increased GFR. And, of course, there's the enlarged distribution space. All of these things mean that you need more thyroid hormone. And so we have pregnancy-specific ranges, if you want to use them, where the T4 and T3 levels are much higher than you would expect in normals. The most important part, I think, is the role of HCG. So HCG, human chorionic gonadotropin, exhibits what's called crossover specificity. Right? It has crossover specificity for the TSH receptor, so that a significant amount of HCG is able to interact with the thyroid and induce more thyroid hormone. Right? It's a wonderful correction in order to get this increased thyroid hormone output. HCG is higher in multiple pregnancies, and so you'll see higher thyroid hormone levels usually, right? And of course it's highest with moles that secrete HCG. It also varies from individual to individual because the interaction of HCG with the TSH receptor varies considerably depending on how glycosylated the HCG hormone itself is. And different people glycosylate at different rates. So one woman's HCG may be really fabulous at stimulating the thyroid, whereas another one doesn't do very much at all. And this just makes that point. So this diagram shows you HCG levels in the blocks, and it shows you TSH in the red line. And as pregnancy progresses, right, HCG rises and TSH falls. Right? And some women get quite a significant degree of thyroid output, and we call that gestational thyrotoxicosis. It's absolutely normal, doesn't need any treatment, but it has all the symptoms of mild hypothyroidism. Right? Some women show really quite suppressed TSH. About a quarter of women will show TSH in a suppressed range. And you can follow that through pregnancy. So which is the best test for thyroid disease in pregnancy and any other place in life? And that's TSH. So why is that? Well, you'll see in this diagram that I borrowed from Carol Spencer, does this show up on here? Yeah. That if you look at the normal range for free T4, which you guys measure all the time, right? This free T4, it's a derived free T4, you'll see that there are plenty of patients with normal free T4 and suppressed TSH. And there are even patients, right, with normal free T4 and increased TSH. So that throws free T4 out of the window, right? It becomes a useless test. But we use it. Not sure why. The only test that matters, unless the patient has pituitary disease or some other interfering factor, is in fact the patient's TSH. It almost always gives you the answer. So that's true in pregnancy, and it's true even in the very elderly. So trying to find the actual prevalence or incidence of thyroid dysfunction in women who are pregnant is not so easy, right? And that's because it's not so common. Hyperthyroidism presenting in a pregnant patient like the case I gave you is unusual, right? Population rate is about 1%. Not rate, the incidence is about 1%. And in hypothyroidism, the data that I'm quoting here suggests it's really fivefold less than that. And that's because hyperthyroid women, right, have a fertility problem. Right? Generally get referred from the IVF program. Hypothyroid women are much more common. They're seen more in the pregnant state. It's only about a 50% reduction in incidence. And miscellaneous is cancer and nodules, and that's another talk. But they also have to be managed in pregnancy. So what are the problems of having hypothyroidism in pregnancy? Well, as I mentioned, it's unusual that it gets to that state. But from what I can see in the literature, I don't see many of these patients, but preeclampsia is one of the major complications, along with thyroid storm that we mentioned earlier. Right? The obstetrical problems, we're going to talk about miscarriages. Premature delivery is a recurrent theme throughout the OBGYN literature as a complication of hyperthyroidism. For hypothyroidism, right, some of the same things, a lot of pregnancy loss, miscarriages, a lot of preterm delivery, but fetal distress and hypertension seem to be the most common. This is a study that I like because it's very clear. These are women who were then treated with thyroid hormone. They have hypothyroidism, but they were treated, and the results are very good. Right? That there was no difference in the low birth weight, no difference in fetal demise, no difference in congenital abnormalities, just some continuing preeclampsia and hypertension in that particular study, and that reflects quite a large literature on T4 treated women going through pregnancy. I want to stress that if you don't treat these women, right, not only do you have obstetric problems, but you have IQ problems in the babies, that I'm sure you're aware of. This is the classic paper from 1999 now, of Haddow, where he went backwards and found sera in the freezer from a series of women, right, who had untreated hypothyroidism, 48 of them. These were not grossly hypothyroid. They were untreated, so their TSHs were increased, but they weren't bad enough to get treatment. And he showed clearly that the IQ of the children, right, that I think were at 9 or 10 years of age at that time, was eight points lower than expected. Now, since that time, of course, there was an outbreak of concern, and this just summarizes a recent review showing the correlation between a child's IQ and the maternal thyroid hormone level. So there are two sets here. Let me be clear that I've got this right. That up on the left-hand side is the IQ, upper left, and at the bottom, upper left, on the left, is the cortical volume, the brain cortex volume. Right? And you'll see that when the thyroid hormone is low or high, right, that there are abnormalities in IQ and brain development. Right? And that's with optimal treatment. You can see in the red dots that with optimal treatment, you can return to normal data. Right? If you overtreat, then you start to go over that curve. So there's a very large literature showing that hypothyroid women who are untreated give birth to babies whose IQ does not reach its potential. And that's the reason why we see these women every month during pregnancy and have them tested for TSH when they're taking their thyroid hormone. Okay, let's get into the immunology of pregnancy, which is essentially a placental transplant, right? There is a maternal effector T-cell response, right? That is shown in this little diagram. And it's going to attack all parts of the placenta, the syncytial trophoblast, the fetal villus, the decidua, and the mother, right, has to respond to her own immune attack on this transplant. Right? So that the placental and fetal membranes are directly exposed to maternal blood, right? And therefore we've got to protect the fetus and the placenta. And the primary way this is done is that we have to protect the immune response from interacting with HLA antigens. So, you'll remember that HLA is not there for tissue typing. It's there to present antigen to the immune system. Right? And so this diagram showing the immunologic synapse shows the antigen-presenting cell on the left, such as a dendritic cell, or even a B cell, even a thyroid cell, actually, and a T cell on the right. And the T cell receptor, right, interacts with a peptide, an antigen, that is combined with the HLA molecule. So the T cell receptor can only respond, right, to the peptide that it's directed against, right, in the context of HLA. So if the mother wants to protect the placenta and the fetus from its own immune attack, what it does is block the HLA by not expressing it. It's amazing, I think. It's amazing. And so this is not a very good slide. I hope you can see it. So that the HLA class 1 and class 2 are both fail to be expressed. Right? So the extravillous trophoblasts do not express HLA or B. Instead, they express these non-classical HLAs, C, E, F, and G. I don't know much about them. I know a little about G, which dampens the immune response by interacting with natural killer cells. And HLA class 2 is also repressed. The HLA-D region molecules are entirely repressed in trophoblast cells. And this is well known. There are also additional proteins that are suppressed that enhance the T cell response. So what's the result? The result is immune suppression in pregnancy, right? It's directed at the placenta and the fetus, but if you just measure antibodies in the peripheral circulation, you'll see that they go down. And this is an old slide of ours, just showing thyroid peroxidase antibodies falling in pregnancy, right? And once the placenta is lost, then the immune system, as with all biological systems, overcorrects. And you tend to get much higher levels of T cell reactivity and antibodies in the postpartum, and that's the cause of the postpartum thyroid diseases. So a long time ago, an endocrine fellow and I put together a project to look at thyroid antibodies in pregnancy. And Alex Stagnaro-Green, who is now Dean of Medicine up in Illinois, having had a discussion with me about going into practice, decided to stay on and do this project. And it's probably typical of everyone in academic medicine that the papers that you put together and the projects you do that take the least effort become the best known. Whereas those that you struggle with, do more experiments for the reviewers, rewrite the discussion 3 times. And no one's ever heard of the paper, right? It's really never read. So this is a paper that's still widely quoted from 1992. Incredible. Actually, I think there's one before this. Anyway, what we did was we looked at thyroid antibodies in pregnancy, and we got these data showing antibodies falling. But he came to me one day and said, there's too many women in this group losing their babies, right? And this is the data that he got, right? So that the pregnancy loss rate in the women with thyroid antibodies was twice the control rate. So, I was really skeptical. But everybody read the paper at the time and started to repeat it. This is just one small review. There have been a number of meta-analyses, and it's a common and widely substantiated observation that if you have thyroid antibodies, your pregnancy is at increased risk. Right? So it's about a doubling. In some cases it's less, in some cases it's more. And the question is why? So, since I had to give this round, I actually tried to put this into a logical sequence. We think there are 3 primary reasons why this should have happened. Right? One is that the women are short of thyroid hormone. Right? Seems pretty obvious. The second is maybe it's the thyroid antibodies and T cells attacking the placenta. And the third is, since it's politically correct, maybe it's something to do with immune instability and T regulatory cell inadequacy. Okay? So those are the 3 theories, and there's evidence for all 3. Here's some evidence. This is a paper from Negro in Italy, where he gave women with thyroid hormone, with thyroid antibodies, he gave them thyroid hormone. Right? So there are 2 groups, thyroid antibody positive in the brownie color, and thyroid antibody positive given thyroid hormone in the green, and a control group. He got a very high miscarriage rate in his TPO positive group. But the important part is that those women with thyroid antibodies treated with a small dose of thyroid hormone had no increase in miscarriages compared to control. Not only miscarriages, but the preterm delivery rate, which I mentioned earlier, was also very high in these women. In women with thyroid disease, is also increased in women with thyroid antibodies, and that was also corrected. So this was met with widespread skepticism and has not been confirmed yet. Studies are still underway, but it's not been widely confirmed yet. But there's a lot of logic, and let me show you the next slide that I think will convince you that it's true. You remember I showed you this slide earlier? As HCG goes up, TSH goes down. Take a look at this. On the left are thyroid antibody negative women, and on the right are thyroid antibody positive women. Across the horizontal is HCG, and on the vertical is TSH. So in the TPO negative, the normal women, as HCG increases from left to right, the TSH goes down, right? Exactly as we forecast. Look on the right. These women are not able to suppress their TSH. They're not able to respond to HCG because they've got thyroiditis. They've got thyroid antibodies that we know correlates with an intrathyroidal thyroiditis. So there's living proof that HCG in these women is not able to respond as nicely as in normals. Now, whether that has any physiologic meaning, of course, is unknown. But that, together with the Negro study, I think is enough to make you want to give these women thyroid hormone. It's not going to do them any harm. Right? What about the other evidence? Oh, I didn't mention this one. This is another study that just came out in the BMJ of 5,400 pregnant women. That's pretty impressive. The thing that was interesting, it's a US study, but only 16% of these women got treated. That's a disgrace, right? It's a national disgrace. And within the treated group, right, there was a decreased risk of pregnancy loss. Right? And that benefit was seen mostly in women with TSHs between 4 and 10. The sort where you're never quite sure whether to treat them or not. What about the effect of antibodies on T cells? Well, it's a well-known fact, certainly in antiphospholipid syndrome, that these antibodies are able to damage the placenta. They've got reasonable data in animal studies that show that the trophoblast and decidua are a target, right, for the immune response, and they call it inflammation-induced pregnancy loss. So this is not a way-out idea that thyroid antibodies might actually influence placental function. Do antibodies cross the placenta? They certainly do. Here's some recent data, not so recent, but anyway, here's some data on anti-TPO in the cord blood across the horizontal and the maternal blood. So, as with all IgGs, they cross the placenta. And a long time ago, we did some studies where we thought we'd try and imitate thyroid disease in pregnancy by immunizing pregnant mice with thyroglobulin. We were surprised, but what we got was a lot of fetal loss. These are some of the data just shown here. When we did this with the same strain, CBA, all right, we got about 76% pregnant mice, and 93% of them had a fetus. When we did it with an abnormal strain, so that we actually imitated human life, right, that the father was different to mother, right? When you did it with the CBA times a BALB-C, we still got good pregnancies, but our fetal loss rate was very high, right? Only 57%. So that suggested that this was an important observation, I think. And then this group from Israel, actually, from Matzulon, did a similar type of experiment, immunized mice, but they went further than we did and should go back to do. They looked at the placenta, and they found that the placenta was full of thyroglobulin antibodies. They didn't really take it to a mechanistic completion and find what those antibodies did, but I think it's evidence in favor of a potential direct placental problem. The third mechanism I mentioned was the T-regulatory defect, right? And Tregs are divided these days into two types. I'm a little skeptical of this division, but the data's getting stronger, I think. So there are Tregs that come from the thymus, that are grown and evolve in the thymus. Those are the Tregs. And there are Tregs that mature in the periphery, so-called P, peripheral Tregs. And it's thought that maybe the peripheral Tregs are more important for suppressing foreign antigens, and that the thymic Tregs may be more important for suppressing autoimmune responses. This follows up on that type of concept, looking now inside those women with peripheral Tregs on the left and those women without good peripheral Tregs. And you'll see that there's a cartoon here showing you that the Tregs are going to suppress that maternal effector response. Whereas if your Tregs are not very good, the maternal effector T cells are going to be able to go in there and disrupt the fetus. I also mentioned earlier that we think that the balance between these Tregs and this subset of T cells called Th17, which are pro-inflammatory, that it's that balance that's very important. So that when you have a nice balance and the Tregs are working well, they'll keep the Th17s under control, and you'll get a successful pregnancy, and you'll get self-tolerance. If you disrupt the Tregs, allow the Th17s to come forth, then you're going to get autoimmune disease and pregnancy complications. Now, when you look in the pregnancy literature, it's really depressing, because there's almost nothing on Tregs in pregnancy, in humans. This is the first paper that appeared some years ago, and there hasn't been a lot of good data since. But you'll see that during a normal pregnancy, the T regulatory subset increases, right? Which is what we want. We want to increase the Tregs, right, and suppress the immune response so that the placenta is protected and the fetus survives. Now, I mentioned that what happens in normal pregnancy for autoimmune thyroid disease is that the thyroid antibodies are suppressed. And the question, of course, is why are they suppressed? And so just recently, one of our fellows, Stephanie Beringer, who I see is sitting there, Stephanie, got involved in a project with us at measuring Tregs during pregnancy, and she just got a grant from the American Thyroid Association to continue these studies. And I think they're producing interesting data. So I'm showing you some unpublished results that we've got looking at Tregs in pregnancy. So this is looking at the percentage of Tregs on the left with three groups. A control group of normal pregnant women, abnormal non-pregnant women, then a group of normal pregnant women without antibodies, and then a group of so-called normal pregnant women with thyroid antibodies, right? And we're looking here at the mounting of a T regulatory response to pregnancy. You'll see that those women without antibodies are able to mount a pretty good Treg response. I'm sure this won't be as tight as this as the numbers increase, but you'll see that the patients we've looked at so far with positive thyroid antibodies are not mounting as good a response as we would expect, suggesting that this may be one of the key causes of miscarriage in pregnancy, particularly since T regulatory abnormalities have been associated with a wide array of different causes for miscarriage. So, in summary, what have we talked about? We've said that pregnancy is a complex physiologic state. It's subject to much potential error. Right? The changes in thyroid physiology are profound and well characterized. The thyroid dysfunction is well known to increase obstetric complications, and pregnant patients with thyrotoxicosis should not be ignored in the ER. There's evidence for 3 potential mechanisms for the association between thyroid antibodies and miscarriage. That is subtle thyroid deficiency, direct action of antibodies and T cells on the placenta and the fetus, or defective T regulatory cells. Thank you very much for your attention. Thank the NIH for supporting my family for the last 30 years, almost 40 years. It's actually since 1980. Thank you.
We have time for questions, please. First of all, congratulations. And secondly, a question. The placenta and the brain are at least 2 important organs linked to thyroid dysfunction. Could you comment on the possible role of the brain when it receives the thyroid replacement, etc.?
Well, I can only say that if you replace normal thyroid function in the mother, the baby is fine. Remember that babies without a thyroid, congenital hypothyroidism, are born normal. So the mother can compensate for no thyroid at all in the baby. Right? But during the first trimester, it's clearly critical. Right? And that's thought to be the time when the brain is developing. And so if mom is hypothyroid, right, even subtly, right, with subclinical, where only the TSH is the abnormality, then clearly brain development isn't as good as it should be. And there have been multiple studies showing a fall in IQ in that group of patients.
So, number 1, it's a wonderful talk. Number 2, I would like to speculate because on one of your early slides you showed that an agonist to dysfunction was trauma. Now, with trauma, you damage cells, they release things. You kill some cells, they release things. So some of the things released may be antigens, which then the immune system reacts to. What do you think of that idea?
Well, it's an old idea, Michael, but it's, you know, it's perfectly logical. It's just that there's no evidence for it, right? I think more likely it's the stress of the trauma. Generally, stress suppresses the immune system, right? And once you get over the stress, the immune system rips back, and you get this over-exaggerated immune response. And if you're a susceptible individual, then you're going to get it. There's some evidence in your favor. That is with pretibial myxedema, which is a horrible disease. Some of you have seen some cases, I'm sure. But in the old days, the way to treat it was the plastic surgeons cut it off. And what happened was it came back rip-roaring worse than ever. Right? That the local trauma of actually removing that that infiltration and the immune activity actually set up a worse immune response. So I think that would favor that sort of response.
Terry, thanks very much. Wasn't there last, in 2017, a study where they randomized pregnant women to follow T4 or TSH to see if there was actually a difference?
Yes,
you know, at 5
absolutely.
years, and there simply was no difference whether they followed the T4 or the TSH?
Yeah. Well, I'm not sure which study you're talking about, but there's a large study in the New England Journal coming from Cardiff in Wales, where they randomized thyroid hormone replacement, right? But these women were very mildly affected. This is TSHs are really very small differences, and they only followed the babies for, I think, 3 or 4 years. So that's still an open question on that particular one. But I don't think those women were affected enough to actually see what they wanted to see. Right?
Any other questions? If not, let's thank Dr. Davies for a great talk.